Okay, so let's make a start. So thank you for joining today's webinar about domestic violence and abuse experienced by people with multiple sclerosis. So obviously this is a very sensitive area that we're going to discuss today. The webinar has been kindly supported by Novartis Pharmaceuticals, but they've had no input into the educational content or organisation of this webinar. This research was kindly funded by the Horn Family Foundation, and this was an issue that we felt as neurologists came to a fore really during the COVID pandemic. So myself and Nikos Evangelou, who many of you may know, and Klaus Schiemerer had all noticed an increase in domestic violence and abuse experienced by women with MS, and the situation of the pandemic with people experiencing isolation and being unable to leave their homes made people more vulnerable. And it was at this stage that we thought about research in this area and found that there had been very little research, and we approached Rachel Horn and her family foundation, and we submitted a bid to fund this research. So we're very grateful for them funding this research, and we've got our 2 PhD students here today. So I'm clinical professor of neurology at University of Leeds and an MS specialist at Leeds Teaching Hospitals. And joining the seminar today are Kharis Hutchison, who's based with me at the University of Leeds and who's going to talk to you about the experiences of women, and Suzanne Britt, who's based at the University of Nottingham, working with Nikos Evangelou. So I'm really pleased to have Kharis and Sue share their experience with us, what their research is telling us. If you have questions, can you please type those into the Q&A, and we've got about 15 minutes at the end to discuss questions. So I'm going to pass over to Kharis.
Hello, as Helen says, I'm Kharis. I'm doing my PhD looking at women with MS and their experiences of domestic violence and abuse, looking specifically at the implications for practice. My background's in human geography and equalities and human rights, with a focus on disability studies. So it's a very interesting project to look at from a sociological perspective, which you'll see throughout my presentation. So just to begin, disabled people are more likely to experience violence than non-disabled people, with an increased risk of experiencing physical abuse, sexual assault, and threats of violence. And this has been identified to be no different for domestic abuse, with a particular increased risk for disabled women. And this has been connected to perceptions of disabled people as helpless and burdens within society, with these perceptions impacting not only disabled people, but outsiders as well, from recognising domestic abuse experienced by disabled people. So disabled people also experience unique forms of domestic abuse, which includes impairment-specific abuse, which is a kind of abuse which exploits any difficulties presented by a disabled person's impairment, and has really been found to have a significantly negative impact on the power dynamic within this sort of intimate relationship and caring relationship, which also can be included. So this has included perpetrators removing batteries from hearing aids and withholding medication. Really significantly for MS, researchers also found perpetrators taunting disabled women about what they deemed to be better times, which were times before acquiring impairment or when they had higher functioning levels. So, whilst current domestic abuse legislation in the UK doesn't recognise abuse from paid carers as DVA, it has been highlighted within research as an area for concern. And this research has found extreme invasions of privacy and deliberate rough treatment from paid carers, as well as social and personal boundary confusion, with it being really difficult for people to recognise the boundary between appropriate and inappropriate touching within this caring context. And the complexity of this carer abuse is really furthered when family members are and or partners are both carer and perpetrator, as being reliant on your abusive partner for care hinders disabled people's increases disabled people's isolation and dependency and hinders their ability to gain help. This is compounded by the common representation of partner carers as caring heroes, who are viewed as being praised for their selflessness, which has been found to make disabled people feel that they should be grateful for the relationship. So there's extremely limited research regarding domestic abuse and MS, with the available research discussing that the impairments people with MS increase their vulnerability of being physically, psychologically, and sexually abused by carers, family members, and partners and spouses. Certain social factors, including high levels of social isolation and unemployment, have also been connected to this increased risk. Within the literature, physical abuse, economic abuse, sexual abuse, and psychological abuse have all been found. A really significant theme within this research has been caregiver mistreatment, neglect, and abuse, with the abusive carers within this literature being family members and external carers. So this included a US nationwide survey, which found that 54.9% of respondents had experienced some form of mistreatment from their carer, such as psychological and financial abuse, as well as neglect. A lack of understanding and disbelief of MS and its invisible symptoms have also been found to negatively impact this carer relationship, with it creating frustration and culminating in abuse and neglect. So the current research considering people with MS and domestic abuse has really failed to explore women with MS's experiences in depth, having chosen to use quantitative methods, as well as really focusing on impairment as the only reason behind women with or people with MS experiencing domestic abuse. So we identified that there was research required that not only explores the DVA experiences of women with MS, but also really aims to understand how to best support them, including what role healthcare practitioners can play in the support journey. So just quickly, the research has used a qualitative approach using phenomenology due to the focus on lived experience, and the research has been designed using a two-stage process, with the first stage using semi-structured interviews, which have been very in-depth with 7 women with MS. And these interviews have focused on topics such as realisation, disclosure, access to support, their idea of ideal support, and the role of healthcare practitioners. And the second stage of the study will use co-production workshops, which will take the non-sensitive findings from the interview stage about what they view as their ideal support, allowing the women with MS to co-produce a Padlet board on the software Padlet so that you can work together to really understand what makes ideal support for them. So looking at the preliminary findings from the research, what we discovered was that the women had described domestic abuse experiences, which really demonstrated a pattern of coercively and controlling behaviour, which manifested in a variety of ways. And this included degradation and emotional abuse, with the women being made to feel like burdens, with perpetrators focusing on symptoms of MS to emotionally abuse them. For example, a perpetrator used a participant's experience with continence difficulties to degrade her. She said that the words started to get a bit more aggressive. So it would be like, well, you're going to piss yourself. If you come with me, there's no toilet. So you're going to piss yourself. It's going to be awful. So immediately it starts putting tiny doubts in your mind to think, actually, you know, am I going to be okay? In this circumstance, the participant found that whilst it originally seemed that her perpetrator was really looking out for her, the words became more vicious, which made her doubt herself and allowed for her perpetrator to increase dependency on him while simultaneously reducing her life. This meant that the abuse really became a disabling force in her life. A lack of understanding and inability to believe the women when they were experiencing invisible symptoms was also expressed, which is really a unique form of emotional abuse reflective of disability, hate crime. And this led to this particular participant experiencing emotional neglect from her perpetrator. Other women also expressed being stalked and surveyed by their perpetrator, with stalking and surveillance being coercive control tactics used by perpetrators which violates and deprives victim survivors of privacy. So one participant found her perpetrator constantly wanting to be in contact with her, which culminated in turning up at her house uninvited often and physical violence. Following the end of our relationship, he continued to make his presence known by liking all her posts on social media, with the aim of making her think he was omnipresent. The use of technology was also experienced by another participant. As she says, I had a tracker on my phone so you could see where I was at all times. There was a Ring doorbell at the front door so you'd know if I was leaving or if somebody was coming. The tracker on her phone results in the control becoming spatially diffused, meaning that even when she was not with the perpetrator in her home, she is always aware that he knows where she is, showing the invasive nature of this form of control. The use of children to manipulate victim survivors is quite a well-documented tactic within the literature, which often results in women remaining in domestic abuse relationships. So children are viewed as an extension of women and are used to coerce, control, manipulate, and hurt them. When considering women with MS's experiences of this, it's important to firstly recognise the wider context of the control which has been exerted over disabled women's fertility more broadly, including the denial of their rights to become mothers and the eugenic history of forced sterilisation, and to also recognise the problems associated with disabled women not fulfilling the societal ideals of what a mother should be. For example, a participant discussed her perpetrator attempting to use her MS to suggest she was unable to look after her child within a custody battle. As she says, he was saying that I couldn't look after my son because of my disability. And this has really been highlighted within previous research as being a successful narrative used by perpetrators to remove children from disabled women. And this fear that this will happen can prevent disabled women from reaching out for help. Several participants also identified them being isolated from friends, family, and help, which included perpetrators making them feel like their families did not care about them, as well as rules being imposed upon them about who they can spend time with. So this really allows perpetrators to control the woman's realities and construct dependency on them. This is particularly problematic for women with MS, since familial support is so important to ensuring their well-being, as well as the isolation that they can already experience within society. One participant, for example, discussed her perpetrator attending her medical appointments with her, meaning she was unable to answer truthfully when asked how she was, resulting in her being isolated from help within this healthcare context. One participant found that the abuse she was experiencing was often disguised as care. This included her perpetrator taking over all household tasks, responsibility for the children, and complete financial control. She recounted that he would often become angry when she would do things for herself, which she excused often as it just meaning that he really loved her. What she's realised now is that he in fact wanted her to become entirely dependent on him. As she said, what he was slowly doing was taking things away from me so I couldn't do them. She expressed that his actions resulted in her feeling that she could no longer look after herself, despite her actually not requiring any care. For certain women, negative views of themselves attached to their MS and societal gendered ideals impacted their ability to realise that they were actually experiencing abuse. For example, one participant recounted that she experienced low self-esteem attached to MS, identifying that society didn't make her feel very good about herself, but it sets exceptionally high standards for women. And this resulted in her feeling grateful for her perpetrator's attentions and not recognising signs early on of poor treatment, really emphasising the negative effects of the narrative that disabled women should feel grateful for any relationship, which allows for problematic behaviour to either be ignored or not recognised. Some women also expressed an internalisation of blame, with the MS being viewed as the reason why they had experienced domestic abuse, which is a really problematic and upsetting narrative for them to hold, as well as there being this double negative impact from the abuse due to both perpetrators and society constructing them as burdens. Significantly, the women have expressed that their experience of domestic abuse has had a negative effect on their MS due to the stress and distress caused by these experiences, which is compounded by the additional life factors that they are dealing with, which has been a really big finding from our research of women with MS have a lot of things that they're going on with their lives, whether they're single mothers or they're dealing with courts or just handling their MS. It makes it all very difficult. And the women have also discussed that trying to heal from domestic abuse is also incredibly difficult and is made more so whilst trying to manage MS. Domestic abuse behaviour is described as something which gets into you mentally and beats you down, quite frankly. So when looking at their support journeys and experiences, the first stage is often disclosure. And disclosure is really not a one-stage or simple process, as it is connected to the process of realization, which, as we mentioned before, can take an extended length of time, and some may find it really problematic and difficult because of the type of abuse that they've experienced. So the women often did not simply tell one person, but a variety of people for specific reasons. For example, one woman didn't want her experience to be hidden and told multiple people in a variety of circumstances, such as her dentist and her ear doctor. Others only disclosed to professionals when they themselves had realised that they were experiencing abuse and decided that they wanted support. The women discussed disclosing to friends, police, and specialist domestic abuse organisations originally, and in some instances then disclosed to a healthcare practitioner at a later point. Accessing support was a very varied experience, with some accessing support easily, whilst others really struggled with, as one participant said, it's been a fight all the way. These difficulties included extremely long wait times, such as one participant who waited 5 months before getting access to support, with no support being offered in the interim period. The women not knowing where to turn for support, particularly in relation to knowing where to find support for legal issues, such as legal aid, and not being proactively referred on to services, such as only being provided a phone number or a name of a service, which really fails to recognise the additional needs and access needs of women with MS, who may be struggling with fatigue and memory difficulties or mental health problems, which mean they required extra help to contact the service. So women accessed a variety of support, including the police, healthcare practitioners such as GPs and MS nurses, adult social services, and specialist domestic violence abuse/rape organisations. So most women expressed either neutral or very negative experiences of the police. This included not believing the police can provide much help, inaccessible police stations and procedures, and a failure to provide a supportive environment where the woman felt believed. One woman whose perpetrator also has MS found the police continuously trying to disprove her experience. As she says, and that's when I got the really snotty officer dealing with it, and she was like, well, could he do that because he's got MS? Another participant discussed having to climb multiple flights of stairs because the lift was not working, despite her having informed them of her MS, and she used a walking stick with no accessible room being offered. Specialist organisations were viewed overall very positively, with services including counselling and workshops being accessed, which were found to help address both issues arising from domestic abuse and MS, such as focusing on self-esteem and self-confidence. Independent domestic violence advocates were accessed by a few women and were seen to be really significant to them feeling supported due to the help that they provide in liaising with police and courts, as well as helping the women work through what had happened to them. The healthcare practitioners which were most commonly discussed were GPs and MS nurses. So GPs were found to have provided really meaningful interactions where the women felt believed and validated, as well as them being seen very quickly, but they provided really limited practical support. Whereas MS nurses in certain cases provided really significant practical support, such as providing a crucial letter about a participant's ability to look after her children for the courts. Other women sadly felt that their MS nurses were very busy and didn't necessarily have the capacity to listen to their additional experience of domestic abuse on top of what they were experiencing with their MS. The women really expressed not viewing healthcare practitioners as a first point of contact for support, and some expressed doubts about the capacity for MS teams to also support them with their DVA. When looking at their versions of ideal support, certain women expressed that they would like to be asked about domestic abuse specifically within the healthcare setting, whilst others discussed thinking that being asked about their well-being would possibly encourage disclosure. Overall, what is viewed as being important for disclosure is being believed and validated, ensuring that it's a private situation, and it being free from judgment and personal opinions. So really evidently meaningful interactions and cultivating strong relationships is really important. When considering how they would like to find out about services, the women highlighted a variety of different avenues, which included QR codes on posters in bathrooms in the NMS clinics and infusion centres, which would take them to a resource detailing all the support that's available for them. Others said that they would prefer to be proactively referred to services, which then reach out to them to reduce the pressure on them and to be more accessible. Significant to them was that they are provided with information about all the options and types of support you can receive, not only for domestic abuse, but also for MS in daily life. There was a desire to have control over this support journey, with the women not wanting to feel rushed or pushed into contacting a service immediately, with this desire for control being connected to the lack of control they have over their bodies due to their MS. The types of support which featured in the women's ideal support are specialist DVA services and women's centres, with a particular emphasis on access to IDVAs and counselling, with independent domestic violence advocates being viewed as really significant due to the specialist knowledge they have, whilst counselling is understood as essential to anyone with MS, and particularly those who've experienced domestic abuse. Self-esteem and self-confidence has really been a struggle for some of the women, with them identifying workshops which help build them up as something that they would like. Finally, the women expressed wanting MS-specific support, such as more knowledge about supporting their well-being or organising personal assistance, because they believe when they're feeling better, they'll have more ability to heal from their DVA experience. And just lastly, when looking at the view of healthcare practitioners within their ideal support journey, the women expressed currently not knowing what support healthcare practitioners can provide, if they can provide support, and feeling that the MS teams are already very busy dealing with MS-related issues. This means that for them to be an avenue for support, there needs to be more information on the support that they can provide. However, most of the women do believe that healthcare practitioners have a central role to play in supporting them. This includes being empathetic people to speak to who are willing to help, and the contact that healthcare practitioners have with women with MS means that the participants view them as being significant in identifying DVA, especially due to the sensitive nature of topics discussed and the relationships which are built over years of care. Healthcare practitioners are also viewed as trustworthy due to their professional status. Currently, most of the women view healthcare practitioners as only focusing on health issues and impairment, with there being a need for a more holistic view and a focus on the person as a whole. To the women, MS is affected by so many factors outside of medicine, which should be considered with questions about their well-being asked regularly to really create this wraparound holistic support for them. Just lastly, healthcare practitioners' role should really revolve around directing victim survivors where to find support to reduce the pressure on them. And this doesn't mean that healthcare practitioners are expected to know everything, but there is this belief that there should be someone within the healthcare setting that they can pass you to and knows exactly what support's available and what support's in your area. And research recently has suggested that this could possibly be an independent domestic violence advocate or independent sexual violence advocate located within the healthcare setting to reduce the pressure on healthcare practitioners. Thank you. I'll pass on to Sue now.
Hi, thank you. Thank you so much, Kharis. Kharis is going to do a Chris Whitty for me, and I'll be to progress the slides. So thank you so much for detailing the work that you've been doing Leeds, Kharis, and I want to talk now about my part of the project, if you like, which is around healthcare professionals' views and perspectives. A little bit about myself to start off with. I am a healthcare professional by registration. I have a midwifery background, so that's what brought me to domestic abuse and safeguarding in many ways. But I'm not familiar, or wasn't familiar when I started this work in the field of MS, so it's been a learning curve for me, and it's brought me into contact with some really excellent healthcare practitioners. So the work that I'm going to talk about at the moment is the results, the preliminary findings of the interviews that I've done, and I'm going to try and draw out of those some messages for healthcare professionals, some of which will align with what Kharis has just described. So next slide, please, Kharis. So first of all, I think it's just worth stepping back and saying why healthcare professionals, just because I think that it's really important for us to recognise that we are still primarily educated in a biomedical model of health rather than a social model of health, although that has been changing over recent years, where there's less of a focus on healthcare professionals just being concerned with symptoms and the prevention of disease, and more around looking at the various intersecting influences that mean that somebody is well or not well, or somebody is in good health or not good health. And I know that that Helen has done some work on the social determinants of health, and I think it's really important because this alters the perspective of what we as healthcare professionals perhaps do. I come from a background where those ideas are pretty well embedded, because birth and early infancy, for as long as I can recall, have been seen from a biopsychosocial perspective. And I think, drawing on what Kharis has just said, I don't think that any of my former patients or my former clients expected me to know all the answers, but they did justifiably expect me to understand the influences that that played a part in their experiences of healthcare. So I think every professional code of conduct that I've looked at in terms of my preparation for this work that I've been doing over the last couple of years talks about the need for health promotion, the need for safety, the need for promoting fairness and kindness, respect, compassion, and educating people about what good health looks like. So it's enshrined in our professional codes of conduct, no matter what area we're working in. So within this, certainly domestic violence and abuse, we can see as a key social determinant of health. Living with abuse is a significant cause of psychological distress. The links between domestic abuse and suicide are becoming much more spoken about recently, and there may well in future be moves to suggest that everybody who expresses suicidal thoughts is asked firstly about living with abuse, whether they've been living with abuse, because it's such a predictive factor. It's the most predictive factor of mental illness, certainly for young women in their childbearing years, and it has devastating effect on children's development in utero as well as outside, and numerous studies point to sexual abuse being predictive of abuse in later relationships as well. Talking to what Kharis has just said about MS and specific nature of MS, the one thing that struck me when I started to look at this work is the extended nature of contact with healthcare professionals that people that are living with MS actually have. And I think there is real insight from a person's journey that is living with MS into their contact with healthcare professionals that could give us some really important future insights into how healthcare professionals respond to the issues of domestic abuse and violence. So next slide, please. So in terms of healthcare response, this is something that is not new. There's a massive body of work about healthcare response to domestic abuse. We even have our own Cochrane review in the United Kingdom that has been carried out around the issue of whether or not we should be routinely asking the question about abuse to people, and that was carried out in 2014. And a fair few controlled studies about not asking and asking were looked at as part of that review. In a number of healthcare settings and in settings that had domestic violence legislation as well. So what they concluded from that review is that if people are asked about abuse routinely, that it does increase the rates of identification, but it doesn't necessarily increase the take-up of support and engagement with support services. And I suspect that might be because often we can ask the question about whether somebody is living with abuse, but that doesn't necessarily mean to say that they will take up the offer of referral into support services. They may not be at a point in their life where they want to do that, and they may simply want to consider what options are on the table. So it's really, really important that we recognise that asking the question doesn't always lead to engagement with support services, but what it has done is put the subject on the table. And I've referred there to an updated systematic review by Miller in 2021, and they support that finding. They say that patients value self-determination in following through with questions about domestic abuse. So they have to be ready to change. They have personal and familial circumstances that feed into their safety consideration, and a number of contextual circumstances like how accessible are services, how available are they, how much they have to do to get into contact with services, all affect their ability to engage and their willingness to engage. But I think as healthcare professionals, the important thing to take from that is that just because somebody doesn't choose to engage doesn't mean as a healthcare professional we're doing nothing or we don't do anything at that point in time. And if you look at I was looking at our Nottinghamshire MASH referral guidance, multi-agency safeguarding hub guidance this morning, and it was saying that even if somebody declines a referral at that point in time, then the practitioner will then document and follow up and monitor the situation. So on the other side of the slide is the practitioner perspectives, and there's been a lot of qualitative work about how practitioners view this issue, done internationally, but very little done in the field of disability studies, and also in particular in the field of multiple sclerosis. But across the literature, what we know is that the practitioner perspective is that they want to engage with this problem. They have a sense of social justice. They see it as part of their professional role, but actually organisational constraints, lack of time, lack of resources can often form a barrier. They often view this issue with fear and anxiety. They don't want to do more harm than good. And they often talk about opening a Pandora's box or a can of worms. In particular, they notice that, or they make reference to the lack of skills and knowledge around asking, and also the need for strong support from their leaders and their managers, and also their organisation. So who supports them in their organisation to take it further? Okay, next slide, please. So the current study that I've been doing is a qualitative study, very similar to Kharis's work. So I've been interviewing people over Teams, over the phone, and a couple of people that I've managed to get to face-to-face. And I've tried as far as possible to interview as many professional groups as would talk to me. You'll notice that I've covered a fair few groups, neurologists, specialist MS nurses, working in different settings. I've spoken to a number of rehabilitation professionals, and I also have spoken to GPs more recently. I hadn't initially thought about speaking to GPs, but so many of my initial participants said to me that I should probably speak to GPs as they were a crucial point in the process and in managing care, that I was able to actually speak to a number of GPs as well. And the interviews with them were very, very insightful, I have to say, in terms of the response to domestic violence and abuse. I could have gone on and on and on and on and carried on for many, many years, but I had to stop somewhere. And I think if I'd taken another decision, I'm always in mind of Prof. Giovannini's tube map of the number of professionals that people come into contact with in terms of their the healthcare professionals that are involved in somebody who is living with MS. And I could have gone on and involved other professionals as well, but I had to take a pragmatic view as to when to stop. Secondly, I chose to recruit across a wide geographical region rather than focus on 1 or 2 sites. And I wanted to do that to capture professional views rather than processes, as these can vary so widely and so wildly as well. So this means that I have spoken to participants from England, Wales and Scotland, although I haven't managed to speak to anybody from Northern Ireland. Apologies for that. Okay, so on to the next slide. So I'm going to talk a little bit about what I've found so far. If you just click as well, Kharis, it might bring on that. Yeah, that's great, thanks. So many interviewees that I spoke to, surprisingly enough, because there is, as Kharis mentioned, so little in the research about MS, many interviewees had direct experience of this issue or worried that it might be happening. And the types of abuse that they had encountered encompassed physical abuse, fraud or economic financial abuse, emotional abuse, sexual abuse, intentional neglect. So they had come across many types of abuse in terms of their interactions in people living with MS, and across the whole spectrum of people living with MS. So people living with progressive disability, but also people who were newly diagnosed as well. Only a few participants described occasions where they had directly questioned somebody about abuse and had received a spontaneous disclosure, if you like. So most of the time, the people that came to them and spoke about abuse were already known to external services or might have already had a safeguarding care plan in place. So in particular, they might be known to the police or they might be known to social care. So participants weren't necessarily uncovering the abuse, if you like, but might have been uncovering a little bit more about the issues. For me, the striking thing was the amount of time that people were in contact with the patients affected by abuse. So during the time, some people were talking about 5 years, 6 years, one case, 10, 12 years. And healthcare professionals during that time were involved with several agencies and were coordinating multiple aspects of care. And I think for that, some of these experiences were profound. And one MS nurse disclosed that she felt very nervous about talking to me initially because of the trauma that she still felt. She felt that she might be re-traumatized by sharing that experience again. And in some cases, the fear of the perpetrator was a real issue. With many people talking about the fact that they lived in the community where their patients lived and where the perpetrators lived as well. So they felt quite nervous about coming forward, especially if there'd been a disclosure and where they had been instrumental in getting extra support, that they felt that there was often resent from the perpetrators, and this led to fear and anxiety on their part. And I've just put a quote in there from one of the consultants about the fact that they do feel that, there are things about MS that do predispose people to certain types of abuse, in particular cognition issues. Okay, next slide, please. So how do people view their healthcare professional role? Well, unsurprisingly, this reflects a lot of what already is spoken about in the wider literature about domestic abuse. Healthcare professionals that I've spoken to feel that they can create a safe, less intimidating environment, a safer space where social issues can be addressed, especially when this is contrasted with other agencies such as social care or the police, even to a degree safeguarding professionals who are often thought to maybe have an agenda. And sometimes, especially if children are present, there's a fear of children being taken away, being removed, because people are regarded as being unfit parents. So healthcare professionals often see themselves as being in that less threatening space, if you like, but also they see themselves as having autonomy around building a therapeutic relationship, and also being able to create pretexts where a suspicion or a consideration of abuse might be followed up by extra visits, extra monitoring, a pretext to bring somebody maybe into clinic, or a pretext for an extra home visit, a pretext to go out with another professional so that they can monitor a situation which might not at that point in time have resulted in a disclosure, but might have resulted in some suspicion. So there's some subterfuge amongst healthcare professionals, and that's not to use that term in a negative way. It's around healthcare professionals having that autonomy to maybe delve a little bit deeper. So relationships were a key element of that approach, and there was a marked difference there in how professional groups saw their own strengths. Perhaps unsurprisingly, specialist nurses saw themselves as addressing a role from a holistic perspective, although that was definitely a marked theme for rehabilitation professionals like occupational therapists. And some clinicians had been in contact with people with MS for many, many years and had been able to track changes in their conditions and address evolving risks, maybe of different types of abuse. However, having said that, lots of practitioners said that they felt that continuity might be under threat as some services became more fragmented and changes were imposed in terms of role. The picture, by the way, is of a dripping tap. One of the healthcare professionals described domestic abuse as being like a dripping tap, that the healthcare professional could get in at the beginning when it was still a dripping tap before it turned into a burst pipe and flooded the house. And I thought that was a really interesting way of describing the problem, that, you know, sometimes it's like a dripping tap, and what we want is to address the issue before it becomes before it reaches crisis point. Okay, next slide, please. So my next few slides are really just about some of the things that healthcare professionals have been saying, and I just think they provide some insights into how people are addressing the issue in practice. So I'm not necessarily going to read them all out, but you can see that there are common patterns, you know, people talking about working on subtle clues, delving deeper, creating pictures. And I think this speaks to this principle that many safeguarding professionals talk about, that we would call professional curiosity, that's at the heart of good safeguarding practice. That very rarely does something come as a clear-cut picture, that it often is a series of just clues, just people maybe not being themselves, people not behaving in a way that we expected, maybe somebody having a low mood, maybe somebody being unhappy. That these are all clues that healthcare professionals pick up on, but what they're trying to do is create a bigger picture. And the quote in the middle, I think, is particularly poignant, in that somebody, you know, can be having a conversation about, I think he was talking about getting in and out of the shower. I think this was from an occupational therapist, or talking about continence, and that those issues can lead to conversations about low worth, and that can then lead to conversations about how people see themselves and how they're seen within relationships. So often these things, as Kharis referred to, are disclosures not a one-off. It's a process and a collection of clues and indications that something may be amiss. On that, healthcare professionals talked about having the ability to challenge with open and frank conversations. And sometimes that's really difficult, and they expressed it as being really difficult because what they didn't want to do was disrupt the professional-patient dyad. Creating a relationship was seen as very important, but then we know from safeguarding that sometimes that can divert us away from sometimes finding out what's happening. And one healthcare professional said in particular it was important for her to have somebody else's perspective, another team member's perspective, because she felt sometimes she needed the objectivity of somebody else viewing the same case and seeing that she wasn't getting carried away with the relationship elements of it rather than what was actually going on. Okay, next slide, please. And this slide just talks to some of the emotions that people expressed. And you can see that, again, they reflect what has happened, or what has been documented in the wider literature, that this is anxiety provoking. It's associated with fear. One practitioner used the word terror. feeling incompetent, sometimes feeling annoyed and irritated if they weren't able to get a referral through to safeguarding, or in particular feeling annoyed and irritated if they'd done a lot of work around a particular case and then maybe the person went back to the perpetrator. Extreme honesty in this regard from the healthcare professionals, saying they hadn't got a clue what to do. They were hurt, they were often frustrated, but that if they had a good outcome, they could, it was an intense feeling of satisfaction. And on the left-hand side, I've put some of the support, the facilitators, time, support from managers, having a pathway in place, having clear lines of referrals, having knowledge, having confidence, and learning from experience. And on the other side, some of the barriers that they mentioned, again, having time or having no time, having thresholds to meet for safeguarding, that safeguarding sometimes wouldn't act because they felt that a person hadn't met the thresholds, and that left the healthcare professional isolated in many cases. Having too many checklists to go through in consultations, and this was just another thing to add on to it. Poor communication within teams or within between other professionals or between agencies often made the situation worse, and that might have led to burnout with the professionals, and sometimes experiencing it themselves. They may have experienced domestic violence and abuse in their own relationships, or a close friend may have experienced it, or even a colleague, and sometimes professionals said they needed extra support in that regard. Okay, next I've got a couple more slides and then we've finished.
So just to say, we just need a bit of time for Q&A at the end.
Yeah. What I'll do is I'll skip the next slide and I'll leave that on there and just go to the preliminary implications, if you like. So if you move on to the next one. So I think some preliminary insights and implications for practice is, and these come from you, these don't come necessarily from me, these come from the healthcare professionals as well, is that the people have learned from other uncomfortable conversations, the conversations that we have around end-of-life care, sexual function, bladder and bowel, mental health, maybe suicide, that sometimes you are having difficult conversations. So do we need to learn a whole set of new conversations? Can we learn some transferability? Practicing rehearsing asking difficult questions. There are no two ways about it. This is difficult, and spontaneous disclosure is rare, but actually learning to ask about something is really important. And sometimes I've done this myself in my own practice, standing in front of the mirror and just learning to ask those difficult questions can be really helpful, or rehearsing them if you know you're going into a difficult situation with your colleagues. Being familiar with local resources, with your pathways, with your safeguarding professionals, with what's available in your area is absolutely crucial. And checking your own assumptions and avoiding hasty sort of let's make a safeguarding referral decisions. So, sometimes safeguarding will refer to those as mechanistic decisions. The fact is we have a problem, let's find out who we can talk to. And sometimes we need to delve a little bit deeper and find out what's going on. And a couple of things, one of the things that I feel really passionate about is practitioners being able to seek support. And practitioners described a range of seeking support informally and formally. So from formal routes if that's available, but most commonly from informal support routes like talking to other colleagues. And I wonder, having done this work, whether there are specific touch points in OS care rather than making every contact count. Are there specific times when this question could be asked about? And on the right-hand side, just a few ideas for how this might be dealt with in training, learning from real stories, such as those narrated by Kharis's participants, learning from other healthcare professionals, group-based work, scenario-based work, and a skills-based approach. So finally, my last slide, and I think this ties into something that Kharis said, is, what I found this really useful for me when I was working with both with students, survivors of domestic abuse, but also in my own practice as a midwife, to actually use this as something to guide me. The lives approach from the WHO, listen with empathy, check my own judgments. It's too easy for people to think that they should leave, people should act, people should put up with it, people should prioritize the children. Remember that people listen often with the intent of answering, and we need to stop doing that. Asking what the person wants. I think Kharis referred to that. Start from that point. What does the person need from you as a healthcare professional? Because that can help you negotiate with your safeguarding teams and put people in touch with services and tailor those services to what that person wants. Validate, listen, and go from a point of believing and understanding. And the last 2 points go together. Safety planning is probably the most difficult, but it can be discussed with a local safeguarding nominated person, you know, and safety planning can be put in place. I think the final thing I would say is it's not easy. It's a knotty, complex, wicked problem, and healthcare professionals have been dealing with this for a long time. I think there's real insight to be gained from this work, and hopefully we'll be able to take it forward. Thank you.
Thanks very much, Sue and Kharis. And hopefully it's been useful for everybody to hear from both the perspectives of women with MS and from the healthcare professionals working in MS. And I think, you know, for all of us healthcare professionals, we are in a privileged position in terms of our roles in the lives of people with MS, and it's perhaps a bit different from other situations, really, because actually we are working with people often through their whole lifetime with MS. So I think one of the things is that this is a learning process for all of us, and we have also got a postdoc who's recently started, and what we're hoping to do in a, you know, for a positive outcome for this work, which has been quite difficult, is to use the women's experience and what we've learned from how healthcare professionals feel about this to actually develop support for healthcare professionals in MS, which, you know, is based on what women with MS tell us they would want. So this isn't the end of this project, really. This is, you know, information to help us get going. So just picking up in the Q&A, and something for Kharis is really around thanks for your presentation, and asking where the participants cognitively intact, and reflecting that MS impacts cognition and their perception of safety versus controlling behavior may be affected. So could you just let us know, you know, did any of your participants have a, you know, significant cognitive impairment?
No, nobody did. But it's even within literature on disability and, you know, specifically intellectual disabilities and domestic abuse, coercive controlling behavior is really prominent within that because they're viewed as easy to control. And within the women that I've spoken to, they didn't need the care that was being imposed upon them. It was being used as a way to make them dependent and reduce who they were as a person so that they wouldn't leave the person. So that was really what was happening in that situation.
And you've got previous experience working with people with learning disabilities, is that right?
Well, there were in a project that I did with my supervisor, but I was a research assistant, that she did a Ministry of Justice project looking at disabled adult victim survivors' experiences of sexual violence. And there were cases of people with learning disabilities within that, but there is specific research that has been done looking at domestic abuse and women with learning disabilities, and they're actually, in that research, is the only time that coercive control has actually been discussed. And the other stuff to do with physical impairments, it actually hasn't been, although it probably is prominent, but it's the only time it's been applied.
Okay, thanks, Kharis. And can I just pick up another question with you? You talked about IDVAs, so can you just tell us what IDVAs are and where are they found?
So IDVAs are independent domestic violence advocates. They are usually normally found within specialist domestic abuse organisations, so places like Women's Aid and Rape Crisis. And they are people who are specifically trained to support you if you are someone who is experiencing high risk violence and abuse, or if you're somebody that's liaising with police and the courts. They help you with that. They'll come with the court to you, they'll support you. But for women, they even have replaced for some like the need for counselling, because they're always available. They're always happy to validate your experience, which has been so important to a lot of the women within the study.
Okay, thanks very much, Kharis. And so I wanted to ask you about the situation that we're often in when we've got a concern about somebody's safety, is that there often is potentially the perpetrator in the same room at the consultation. And so did any of your healthcare professionals talk about managing that issue of trying to separate someone from the perpetrator and how to do that in a sensitive way within our clinic settings?
Yeah, I think a few people had got their strategies for doing so. I mean, it is difficult, isn't it? You know, I work because often if somebody has mobility issues or somebody's needs that other person there to support them, then that can lead to a little bit more difficulty in getting somebody on their own. So, you know, practitioners spoke maybe about taking somebody out for a urine sample, or taking somebody out to be weighed, or taking somebody out for a you know, blood pressure to be taken, and explaining that they needed to do that on their own. So there were those kind of setups. People talked about the infusion clinics. A lot of the infusion clinics, people wouldn't they wouldn't have partners attending at that point in time, so that was a really good place that they could maybe speak to them on their own. Or for example, a lot of people that spoke to people in their home, they felt that they were able maybe to create some level of subterfuge where they could get the person maybe to leave the room or disappear and make a cup of tea, or you know, and some healthcare professionals went with other healthcare professionals, so that one of the person would perhaps take one person off and maybe do a bit of chatting with them, talking about how things are, and, you know, show me this and show me that and show me the other, and then they were able to talk to the person. So people you know, had a range of strategies, if you like. But I do think, again, there's some specific work maybe needs to be done. It's all right saying take somebody out of the room to weigh them, but that might not be, you might not be able to do that with somebody who is attending a clinic who's got mobility issues.
Okay, no, thanks, Sue. And someone else asked why we weren't considering men in our study, and I think we are aware, obviously, that men with MS can experience domestic violence and abuse, but actually there are probably many more women that experience domestic violence and abuse, and actually there are specific issues around women's experience, which in a small qualitative study like this, it you know, actually it's difficult to reach this population, as I'm sure most of you understand. So in fact, identifying women with MS, you know, especially when people aren't disclosing to their MS teams, as has come up from the research, that MS teams aren't the first port of call. So I think the learning we have with women with MS is really important, and this is actually some of the first qualitative work in this area. But this doesn't mean that men with MS don't experience this as well.
Yeah, and can I just say to that, Helen, just that I hadn't, within talking to the healthcare professionals, it wasn't a question that I specifically gave a gendered question too. So within the research that I've done, some of the experiences have related to men with MS who've been subject to abuse. So there is an element of the work from the healthcare professionals that has spoken to that as well. So I think it is something that, you know, potentially, you know, will have some elements of discussion in my findings.
Okay, thanks, Sue. So thanks everybody for joining today. I mean, thanks in particular to the women with MS who gave their time to these in-depth qualitative interviews, and to all the healthcare professionals, and to Ruth, who's on the call today, who's really helped with the networking of healthcare professionals for Sue's interviews. And hopefully we'll be back in touch with everybody when we've done some further work really on how we take this forward to support MS healthcare professionals. So thank you, everybody, and thank you, Kharis and Sue. Thank you.
Thank you.